Okay, let's go ahead and pick up where we left off. So we're talking about cardiovascular system, and we're going to be taking a look at the two cardiovascular pathways. So we have the pulmonary circuit and we have the systemic circuit. So basically the pulmonary circuit's job is to circulate blood to the lungs. That's the transfer, that's the right side of the heart. And then the systemic circuit circulates blood through the body, the rest of the body, through the system. And this is kind of what it looks like. So here's your right and left side. So basically you have your right side, which is your pulmonary, and your left side, which is your systemic. And we kind of already saw this a little bit, right? So basically from your right atrium, you're basically going to pump blood into the right ventricle. And when the ventricles contract, that's going to go through the pulmonary side into the pulmonary trunk, off to the lungs to exchange oxygen and CO2. And then from there, it's going to deliver that oxygen-rich blood to the left atrium. And then when the atria contract again, that blood's going to go into the ventricle, the left ventricle. And then when the ventricles contract, that blood systemically is going to be going through the aortic arch. It's going to go through the descending aorta, feeding all of your organs, and of course, up to your head and shoulders, feeding your brain and so forth. And so that's basically your right and left side. And so they have two different, very different sorts of things that they have to deal with, two different pressures they have to deal with. So in the pulmonary circuit, basically you have your right atrium pumping that deoxygenated blood into the right side. And so it basically moves it into the pulmonary trunk. So when it gets into the lungs, this is where you're going to get your gas exchange, right? So this is basically where you're swapping out your oxygen for your CO2. And that's typically due to the pressures of the oxygen and the CO2 there that causes those to diffuse. Normally, we talked about diffusion earlier, right? So we basically the movement of molecules from a high concentration to a low concentration. So that's basically what's happening. They're basically moving across your pulmonary capillaries by diffusion. And so these capillaries then will do most of the gas exchange, just like they do in your tissues. And then they're going to be collected up by the pulmonary venules, merging them into the pulmonary veins. And then they will go into the left atrium. And then from there, you now have oxygen-rich blood, which will then be on the systemic side. So once you enter into the left side of the heart through the left atrium, you are now on the systemic circuit. So you go from the left atrium into the ventricles. And then from there, you're going to be moving out to the rest of the body, going through, first of all, through the aorta. And then they're going to branch into smaller and smaller arteries, like we saw before at the beginning of the chapter, into arterioles, which then lead to the systemic capillaries. This is basically the capillaries that we associate with being at our tissues. And then, of course, those will be collected up by systemic venules, which will then drain into veins, which will then move to the superior and inferior vena cava, and then right back where we started at the right atrium. So essentially, we complete the loop. So this is kind of what it looks like throughout the rest of the body. So you can see how you don't just have the central vasculature, but you can see you're delivering basically arterial blood to the tissues throughout every nook and cranny of your body. And then you're collecting that blood up from the tissues, heading it back to the heart. So it's basically a big, gigantic loop, similar to actually what taxis do at the airport. If you follow a taxi at the airport, what they're basically doing is a gigantic loop. Buses are the same way, right? They're just a gigantic loop half the time. So they basically go from one pickup spot. They kind of go through a series of predetermined destinations, dropping people off. And then they kind of come right back to the original destination to pick more people up. And they just basically kind of go around and around and around and around. So that's basically how transit works. So in the systemic circuit, when blood leaves the heart, remember, first of all, it's under pressure. And the first place it goes is in the aorta, right? So that basically supplies blood, and it disperses out from the aorta to regional arteries, right? The example we use here is the renal artery. That's the one that's going into the kidneys. But it'll go into different arteries as they're branching out from that aorta. So you have a thoracic aorta, an abdominal aorta, and it's basically shooting out arteries to these different regions in your body. The renal is a perfect example, which is feeding blood to your kidney. And then, of course, your capillaries in the kidney are inside the kidney. And so the kidney cells will be fed with that arterial blood, and then it'll go through the capillaries, and then it'll be picked up by the renal vein, which basically comes out of the same area, roughly, of the kidney. But in this case, it's heading back toward the heart because it's basically done its drop off, and now it's going to go and connect the loop. And then it's going to be heading toward your inferior vena cava, which will go back up to the right side of your heart. Okay. And this is kind of like the basic idea. So not all blood has to go all the way to the tips of your toes, right? It's just the blood that goes to the tips of your toes has to go to the tips of your toes. The rest of the blood in your arterial system can basically go a much shorter distance, right? So for instance, your kidneys, which are right about here, is much a shorter distance than if you have to go to the tips of your toes. Okay. However, you still need the amount of pressure that you need in order to get to the tips of your toes. That means that the blood coming to your renal artery potentially could be under fairly high pressure. Okay. So there are a couple of, and this, by the way, this kind of going from aorta, renal artery, kidney, renal vein. So this is basically where the capillaries are. Back to the inferior vena cava, and then back to the heart. This is basically the pathway of blood. Remember we talked about the arteries, and then we went arterioles, and we went capillaries, and then that, so that whole trajectory is basically the same thing. The only difference is you're kind of putting a little bit more specific descriptors on it. So rather than arteries, we're specifically talking about the aorta. And then we get smaller arteries, which are not quite arterioles, that are the renal artery, and so forth. And so we kind of had this similar type of trajectory. We've done this now, what, 3 or 4 times now in this chapter? This basic pathway of blood through the body. Okay. Now, there are a couple of more specific and specialized hookups that you're going to see in your body, what's called portal systems. And so these are what's called special routes. So they don't follow the normal pathway. So what is the normal pathway? Well, this is the normal pathway, right? Normally, if you're going to a capillary bed, right? So here's your heart. If you're going to a capillary bed, so here's my capillary bed. And you want to go from one capillary bed to, say, for instance, I want to jump over to this one. You can't just cut straight to it. The way you do it is the blood comes from the artery. It goes to the arteriole, to the capillary bed. And then you have to go through the capillary, get collected by the venule, and you have to basically be moved back to the heart through the venous system. You got to go through the pulmonary side of the heart to the lungs. You got to go through the systemic side of the heart to the aorta, and you have to be redelivered and repumped. And this time you make your pathway to the new capillary. That's how it normally works. However, in some cases, there's what's called a short circuit or shortcut, and that's called a portal system. Basically, this is essentially, it connects 2 capillary beds together, usually with a portal vessel. So for instance, you can cheat here by creating a portal vessel that will just basically short circuit from one capillary to another. So this basically would be the portal vessel, short circuiting, kind of giving you a bit of a shortcut from one capillary bed to the other. That way you don't have to go all the way back around and go through the lungs and then go back out the aorta and then go through the rest of the body. It's a long way to go, right, to get to just right over there. Right? Sometimes if you drive in an unfamiliar city with lots of one-way streets, that happens to us, doesn't it? Because you realize you're going this way and you're like, wait a minute, but I just need to get right over there. And I can't turn that way because it's a one-way street. So what do you have to do? You have to go all the way around the block to get to that one point, right? It's the reason why a lot of people don't like one-way streets. So the biggest portal system we actually have 2 main portal systems in our body. One is the hepatic portal system. And this is a really special system because what this basically does is this one is bringing nutrient-rich blood to the liver. Now, remember, basically the portal system, the hepatic portal system, is venous. It's the venous blood system. That absorbs nutrients from the digestive tract. So when you eat your food, you break it all down, you digest it all that absorption, where's that going? Into your bloodstream. Yeah, but specifically it's going into these portal veins, which basically wrap themselves around your intestines, which is where most of your absorption is occurring, and just about every other organ in your digestive system. And what it's doing is it's taking that newly absorbed nutrient that you just ate, and it's sending that on along with all the rest of the digestive organs. It's like a big tributary river system. We have all these different veins wrapping around all these different digestive organs, funneling all this newly absorbed nutrients all the way toward the liver. And then the liver will basically metabolize everything you've eaten. And so before it gets released to the rest of the body, everything goes through your liver, right? Think of your liver as sort of like a mother, right? Feeding a baby. The baby doesn't just get to stick whatever it wants in its mouth, does it? It goes through mom first. And what does mom do? Or dad, right? What do? They check it to make sure it's good, right? So they kind of, if it's like a little baby food sort of a thing, they kind of make sure it's all, nice and good and mixed up, and they'll check the temperature to make sure it's not too hot, right? And then they'll make sure it's a correct amount of portion. You can't just get a big old shovel and cram it into a baby's mouth. That's not going to work, right? So you got to kind of like the little half spoon piece, right? So before the baby even touches it, mom's already checked it down, gone through quality control, safety control. It's basically looked at everything, right? So up and down. And then once it gets into the baby, it's good for distribution. That's exactly what the liver is doing. So everything you put in your mouth, everything you digest, whether it's food or medication for that matter, it goes through your liver, gets digested and metabolized. And then once it's all checked down and it's okay, then it releases it to the inferior vena cava for distribution to the rest of the body, right? And so that portal system is a really critical system because it's involved in that process. And so typically speaking, your liver will be doing lots of metabolism, but they'll be making lots of different types of proteins from these amino acids that you're absorbing. And you'll also be storing glucose in your liver as well. So your liver does a lot of things. It'll be removing toxins and pathogens. This is, by the way, the reason why when we do drug development, one of the things we always have to do is administration of the drug, right? Think about it this way. Have you ever wondered why some medications are oral and others are injection? Sometimes a lot of patients don't realize why it's an injection. The reason is because during drug development, what they found out was that injected drug, when you just took it orally, is basically devoured by your digestive system. Like if it's a protein, insulin, for instance, is a good example of this. Insulin is a protein hormone that regulates your blood glucose. The reason you can't take it orally is because it's a protein. Your digestive system is designed to basically digest protein. So your insulin will never make it out of your digestive system alive. So you're basically eating a very fancy protein tablet if you're going to swallow insulin, which is the reason why you inject it, is because you need that insulin protein to be in your bloodstream regulating blood glucose. So you're bypassing the digestive system in the liver. The other one that we oftentimes see is sometimes we'll have a medication that looks really great on paper, but then when we give it to somebody, it goes through the liver. The liver metabolizes it into some sort of a secondary byproduct that has absolutely no therapeutic value whatsoever. So even though a person takes it, it's like the liver just totally destroys it and you get no therapeutic value from it. In that case, they've switched to like, well, what if we, as an injectable, right? Bypass the liver so it doesn't defang this one, inject it, and that way you can get the therapeutic benefit from it. Okay, those are all issues that is happening during drug development, which is one of the reasons why the FDA process is such a long process, is because there's a lot of different little things you have to fix in that particular area. But that's what your liver is doing. So once it's basically removed all these toxins and pathogens from the blood that's being delivered because you ate a pathogen perhaps or something of that nature, or there's a pathogenic toxin from like a bacteria in your system, it'll destroy that and make sure that that's not going to be toxifying your entire body. Then it basically releases that to the rest of the system through hepatic veins. And then the veins will drain into the inferior vena cava. And of course, we know the inferior vena cava will go off to the heart for distribution. So that's a main distribution process. So let's take a look at some of the more nitty-gritty pieces of exchange at the capillaries. Remember, we said that the capillaries, even though we kind of talked about them a little bit, we haven't really talked about what's exactly going on at the capillaries. Or the capillaries are an important place, the most important place, because this is where all that physiological magic is occurring. This is basically where you are doing your major exchange. This is where you're feeding your cells, and you're also picking up their trash. Okay. The most important moment in your cardiovascular system. There's basically two forces that drive the fluid in a capillary system. There's an inward force and an outward force. So there is a force that will push or drive fluid into the capillary and a force that will drive it out of the capillary. Now, generally speaking, when we take a look at the outward driving force, what's behind that is blood pressure. And so the blood pressure going into the capillary is what's creating that push against the capillary wall. This is higher at the arterial end and lower at the venous end. But this is basically what's causing the fluid to push against the capillary and causing the nutrients of the capillary to move into the tissues. Basically, it's like a strong tailwind, okay, against that. Now, generally speaking, what will cross the capillary membrane? First of all, fluid, water, things like ions and oxygen, CO2, those things will cross easily across the capillary. However, big stuff will not cross, okay? Blood, for instance, blood cells, plasma proteins, those won't cross. They're too big. So the capillary wall is like a sieve. It's got a pore size to it. Stuff that's big enough or too big will stay behind. Stuff that's small enough will scooch through those pores, and they'll basically move into the tissues. Now, there's a couple of things that are, we talked about the push, right? So we tend to think of this outward force as a push, and blood pressure is like a push force, right? It's pushing at your back, just like a tailwind. However, there's also a pull. The pull force is osmotic pressure. This is the pull. Now, what does a pull do? So pull will basically pull water into the capillary, and it's typically by osmosis. So remember, when we talk a little bit about osmosis, I think we talked about this when we talked about diffusion in the diffusion chapter, right? We talked a little bit about osmosis and diffusion. And what was the mantra of osmosis? Salt sucks. Basically, the saltier something is, it'll have a sucking effect on water, right? And so this is actually how you move your water in your body. You don't move your water by saying water move here. You move it by creating a salty area, and that salt has a sucking effect on the water. So the water always chases salt, just like my beagle always chases the Alpo snap, right? So in this particular case, what happens is the osmotic pressure builds up, creating a higher concentration inside the capillary, which creates this sucking effect. It's becoming more and more and more concentrated. And that's going to create this sucking effect on water outside of it, which is going to draw water in or pull water into the capillary, but it's going to happen at the venule end, okay? Why is it more concentrated? Because we lost water on the arterial end, right? The blood pressure is pushing water out of the capillary into the tissues. Everything inside the capillary is becoming more and more concentrated. So that finally at the venule end creates this concentration that pulls the water in to the venule. Not all the water moves into the venule. Some of that will linger behind. But that excess fluid will move into the lymphatic capillaries and become part of the connective tissue lymph that we learned about also in our tissues chapter. Okay. And so this will eventually be sent back to the cardiovascular system to be reincorporated into your blood. Okay. So the lymph system is important because the capillaries in your tissues act like sponges. Mopping up excess water. So if this didn't happen, what's going to happen is fluid would start to deposit in your tissues and your tissues would start to swell. And you get lots of swelling in your tissues because you get a lot of water stuck, trapped in there that didn't get absorbed. And this is actually something we still encounter when we have an issue with our cardiovascular system and we're not able to actually mop up this excess water efficiently. We start to get swelling. And that's usually because of a pathology in your cardiovascular system. So let's take a closer look at this and let's get down to the nitty-gritty. So you have your blood pressure basically coming in to the arterial, being pushed at its back by the blood pressure. As it moves into the capillary, what's going to happen is you're going to have a strong outward push. This is due to the blood pressure. And a lot of water is going to be leaving. So you're going to have lots of water leaving. Your oxygen is going to be leaving. You're going to have amino acids leaving. And so everything is going to be moving out at the arterial end. However, the inward pull, if you notice these little green arrows here, are very small at the arterial end. So the overall direction is outward at the arterial end because you've got a massive blood pressure push against that capillary wall. At some point, however, what's going to happen is as you lose water in your capillary, it becomes more and more and more concentrated on the inside. And so your osmotic pressure will start to increase and increase. And not only that, but you don't have an infinite amount of water, do you? At some point, you're going to run out. So you notice that your water arrow starts to get smaller and smaller and smaller. So that push at your back is getting lighter and lighter and lighter. And so, sorry, just because I screwed this up last time, I just got to prove to myself I actually did screw it up this time. A little OCD thing kicking in there. Sorry about that. So basically what's going to happen is as that gets lighter, your osmotic pressure will increase because it's getting more and more concentrated left behind. What that means is it's going to start to suck things in. So carbon dioxide is going to start moving in by diffusion. Your wastes are going to start moving in by diffusion. And also water is going to start moving in by osmosis. And so you reclaim a lot of that water at the end. So notice by the time you get down to the venule, you'll notice that most of your main pressures at this point are osmotic in nature. So you got a stronger pull force now at the venule end, pulling those things into the capillary. By the way, those things you want to be pulled in the capillary, right? Because CO2 is trash. You got to pick it up to get rid of it. Your excess carbon dioxide is trash. You got to pick it up to get rid of it. Your wastes, your organic wastes are trash. You got to get rid of it. Your water, you need to reclaim it because you need to restore your blood pressure, right? So basically, you kind of see this pendulum-like shift from the push forces at the arterial end, basically moving toward the pull forces, pulling all that stuff into the capillaries at the venous end. It's kind of what it looks like in 3 dimensions. So you can basically see your blood is basically going to come through the arterial. It's going to start moving through the capillaries. And you're going to be able to sort of direct that blood flow with your precapillary sphincters. But as it basically gets rid of oxygen, picks up CO2, you're going to have this sort of purple-like transition zone where you're kind of halfway there, halfway not. And then eventually you're going to get to the deoxygenated venule side where it'll be recollected up and collected in a venule to be delivered to the heart to be recharged with oxygen in the capillaries, in the pulmonary system. Notice you also see excess fluid and water entering freely the open ends of your lymph system as it basically comes in to your lymph system, mopping up that excess water. So in your capillaries, it's not just veins and arteries. You also have capillary vessels there as well. that are managing and balancing the amount of water that you have collecting in your tissues. Okay, let's go ahead and take a look at some disorders. What happens when it all goes horribly wrong? So cardiovascular disease, CVD, this is a big one, right? So this is one of the leading causes of death, especially in the West, for both males and females. As a matter of fact, many of us, either we know somebody we love who's struggling with cardiovascular disease, or we ourselves are struggling with cardiovascular disease. Or if we're too young for that, we will struggle with cardiovascular disease, or we will know somebody we love who will struggle with cardiovascular disease. It's very prevalent, and so it really hits home. Most people have somebody they know in their family that has some sort of heart disease that they're struggling with. Okay, it's just that common. So you can break this into several different types of disorders. So disorders of the heart or disorders of the vessels. Disorders of the vessels, the most common one we get is hypertension. So that's basically high blood pressure. Normally, this is also coupled with or a cause of or from atherosclerosis, which is hardening of the arteries, blockaging of the arteries. And so the reason why these are a concern is because with both hypertension and atherosclerosis, you can actually, these can lead to stroke, which is basically deprivation of blood to the brain, heart attack, which is basically deprivation of blood to the heart, or an aneurysm, which is essentially the bursting of a blood vessel due to pressures and weakening of the wall. So let's take a look at hypertension first. So high blood pressure, we basically define this as having a blood pressure of 140 or greater, or a systolic of 90 or greater, right? And no, this isn't just a peak, right? This is consistent or continuous, chronic. Not just episodic blood pressure, right? I mean, for instance, if you basically go to Walmart and you measure your blood pressure there at their little machine and you see it's over 140, a cardiologist is not going to entertain you, right? Because they're going to be like, well, of course you have high blood pressure. You're at Walmart. I mean, that's where you go to like lose your humanity, right? That's like the black hole of the soul for humanity. So your blood pressure will normally peak under stress. I don't know about you guys, but I can't not go to Walmart because the prices are low. But at the same time, every time I go to Walmart, my stress levels just go boop, 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 boop. And there's not a day when it doesn't happen, right? And I can see it happens to everybody else because most of the people I see at Walmart look like they want to hurt me if they had a chance to get away with it legally. And we all know that's probably true. We probably experienced that, right? We have entire TikTok accounts based on people you see at Walmart, right? And they're kind of funny because, well, they are us, right? So we are all people that we see at Walmart from time to time. But that's not what it is, right? What we're talking about is chronic exposure and chronic high pressure. Your pressure normally troughs and peaks. Remember, your blood pressure is homeostatic, which means during the day, it will peak and trough, and peak and trough, and peak and trough, and peak and trough. And as long as it's doing that within its normal range, its normal homeostatic range, you're good. Even if it peaks a little too high, you're not necessarily bad because ideally you have physiological mechanisms which will bring it back down into normal range. The idea is if you're stressed out at Walmart and you're getting just like, ready to strangle somebody, or many people, or you're afraid because a lot of people are looking like they want to strangle you, then it's easy. Just leave Walmart and get somewhere else and relax, and you'll come back into the normal range, right? So when we're talking about high blood pressure, we're not talking about just high blood pressure. We're talking about high blood pressure chronically over several different life activities. Now, if you're working out and you tell me your blood pressure is 140 or something like that, I'm not impressed because your blood pressure is supposed to be high. When you're working out, the demands that your body is putting on your heart are much higher because your muscles are working and they're consuming more energy. They need more blood because you're working out. Now, if you were to tell me that your blood pressure was over 140 and you were taking a nap, now you've got my attention. Because at that point, your blood pressure should be low because your body is not demanding a lot of extra energy. So it's all relative to what you're doing. But because typically you don't know from one moment to the next whether your blood pressure is high or low, we oftentimes refer to it as the silent killer, because oftentimes there's no symptoms associated with it. And a lot of times, by the time you realize what's going on, it's like you're well into your hypertension. Okay. The problem is high blood pressure chronically over a lifetime will create a lot of wear and tear on your system. It'll start to degrade the functionality of your kidneys. It'll start to lead more likely to increased heart attack and stroke because you're just have abnormal pressures in your system. Now, how do we treat it? With diuretics. So basically, because blood is mostly water, so the best way to reduce your blood pressure is to reduce the amount of water in your body by basically urinating it out. So essentially, if you urinate out your water, that's one way to basically take the water out of your blood, reducing your blood pressure. And so oftentimes blood pressure medications are diuretics. They essentially basically get you to offload excess water. That keeps your blood pressure down. Okay. And that's how they work. One potent diuretic is actually one I'm drinking right now. Coffee is a potent diuretic. If you drink a lot of it, it will make your kidneys work overtime. So one of the reasons why if you don't drink any coffee, non-coffee drinkers don't get this because they don't have to deal with this. But like when I don't drink coffee for a day, I can like go like most of the day without even going to the bathroom, like once, without urinating. Like even if I drink a little bit of water, still water won't do it. If I drink coffee and water at the same time, I mean, I got to go like every 30 minutes because you've got a combination of a lot of water in my system because I'm drinking water combined with a potent diuretic, which is causing you to urinate out more water. So coffee can be a very dehydrating sort of a thing, right? So just remember that when you're like going to be away from a bathroom for a long period of time, don't tank up on caffeine and water at the same time, right? So leave the caffeine alone because then you got a fighting chance. Like just to this day, that's what I do. Like if I'm going to know I'm going to be locked up somewhere, like in an all day meeting and I'm not going to be able to get out or any breaks or anything like that, I tend to sort of back away from the coffee a little bit. I'll drink my water to stay hydrated, but I'll really diminish my coffee because I don't want to have to be getting up like, you know, all the time because I have to stay, you know, in that particular group. So that's a thing. So atherosclerosis, that was the next one on our list. So basically this is the buildup of plaques in your blood vessels. And so when you basically have a blood vessel, the liner in your blood vessel will start to build up this plaque, this lipidy type of a plaque. And so what'll happen is as this plaque builds up, it starts to diminish blood flow. So the blood will basically hit this like water in a babbling brook hitting a rock. It'll create a lot of turbulent flow and it'll create a lot of problems to normal blood flow going through there. If that blocks this artery too much, then this will essentially create a blockage in your artery and it could create and diminish blood flow to a particular area and that could cause problems. Okay. Now, when we take a look at these blockages or this plaquing of blood supply of your arteries, we have a couple of different types of occlusions. So these are basically occlusions or the types of occlusions of the vessels that we can get. The first one we have is what's called a thrombus. So this is basically a clot that typically stays put. So it's a blood clot usually, not the same thing as a plaque. Because a plaque happens underneath the liner. A clot happens within the stream, okay? So plaques are difficult because you can't just get out there. Because a lot of times my patients, like when I was in the cardiology office, my patients ask me, it's like, well, how come you guys can't just get in there with like a test tube brush and just scrub it all out, you know, clean it all out like you do with plumbing pipes? It's like, well, because it's actually not on the surface of the pipe. It's actually underneath the surface of your arterial lining. That's why you can't get in there and just scrub it all out. Because the normal liner of your artery is on top of the plaque. It's building up underneath. And that's the problem. Whereas clots are actually in the bloodstream flow, right? So they're actually, they're either stationary, which means they're lodged in there, or an embolus is basically a clot that detaches and basically moves. So this is a mobile clot that's moving around to other types of sites. And then a thromboembolism is an embolus that's moving and it becomes lodged or stuck in a vessel. So like a pulmonary embolus, typically what you usually hear in clinical settings when you hear embolus is they oftentimes refer to embolus as a thromboembolus. Basically, it's something that, like, for instance, a pulmonary embolus is something where you've had a clot somewhere, it's broken loose. Like a lot of times people will say, oh, I threw a clot. That basically means they've got like some sort of a clot in, say, their peripheral artery, and it basically breaks off, and then it travels through the system, and then it kind of gets lodged in the lungs somewhere, and that's a pulmonary embolism, where you start to get that lodging in there, and that's going to disrupt blood flow in that area. So it's kind of what it looks like. So normally you have cholesterol that starts to stick in the arterial lining and forms these kind of hard plaque-like crystals in the lining, and that starts to push its way into the blood flow and starts to block that blood flow to the heart itself. So the third one we had was stroke, right, which we call cerebrovascular accident, which I always thought was kind of odd, right? It's like, well, what kind of an accident is that? That's, yeah, it's kind of strange to call it an accident. Like, whoops, sorry, didn't mean to have a stroke on you, right? It's like, but this is basically what happens when a cranial artery is blocked or burst. So both of these result in deficiency of blood flow. So if it's blocked, you're going to be that what you're going to block blood flow to a particular area of the brain, or if it bursts, you're going to destroy the blood flow to a particular area of the brain. But Lizzie. It is an aneurysm, yeah. So you can see there's a lot of overlap between some of these the terminologies, right? So for instance, an aneurysm is actually specifically focused on the actual bursting component of it. So an aneurysm will essentially create a stroke, the same way a blocked cranial artery will. So like symptomologically, like clinically, an aneurysm in the brain would present itself as a stroke. But usually, we usually kind of think of strokes as something a little bit less severe than an aneurysm. Like if you blow an artery in your brain, probably that's a one-way trip. You're probably not going to survive that one, right? Whereas a stroke has a lot of different layers of severity to it. So you can oftentimes survive a stroke depending on the nature of the, or the degree or the position of the blockage or of the break itself. Makes sense? So it's kind of a slightly different grade, if you will, of bursting. So the area of the brain that lost its oxygen is going to be the part that dies. And so the reason why we get variations in severity is because of where it happens. For instance, if you essentially block or burst the cell, but it's kind of like at the terminal point, then there's not going to be a lot of brain cells that lose oxygen. So you're going to have a much smaller region of the brain that gets damaged. If, however, you block it or break it at the beginning of a major conduit to the brain, you're likely going to do much more global damage to the brain there. It's going to be a much more severe stroke. Okay. So depending on where it is, that dictates like how your stroke is and what your recovery is. But typically it kind of comes across the same. So oftentimes you'll get, usually it's unilateral. So you'll get numbness in the hands, or inability to see. So loss of your senses, difficulty in speaking, and oftentimes this will be unilateral. But unilateral, that basically means that one side of the brain is experiencing that deficiency. That's typically what happens in the stroke. Okay. So heart attack. So we had heart attack on our list. This is myocardial infarction. This is basically a similar sort of a trajectory. This is essentially when your myocardium dies because of a lack of oxygen. So for instance, if you've got a blocked coronary artery, we took a look at those guys before, those are the vessels supplying the heart with blood. If you block those guys, then you're going to deprive the heart muscle of oxygen and they're going to die, and your heart's not going to be able to pump anymore. And so generally speaking, this will oftentimes start with angina pectoris, which is basically chest pain. And this is usually caused by not a fully blocked coronary artery, but a partially blocked coronary artery. If it's fully blocked, you're probably dead. And typically speaking, when you go into a cardiologist's office and they check to see if you've got a blockage in your artery by doing a stress, they're not necessarily interested in the arteries in your periphery, the artery or anything like that. They don't really care. What they're looking at is that coronary system. One question: are the coronary arteries and veins in your heart feeding blood to your heart, draining blood from your heart? How clean are those? Those are the ones they look at. So when you are having a heart attack, it's a blockage in one of those coronary arteries. That's what's happening. Okay. Now we can treat this with different drugs. We can use blood thinners to get the blood through that blockage a little easier and smoother. We can also dilate the blood vessels with some drug dilators. They're called vasodilators. We can also drop a stent in there, which is just like a little mesh tube that expands, and we can just basically expand that. It's like a little tube that holds your artery open. Okay. There's lots of different ways to do that. Now, Lizzie brought up aneurysm. And so aneurysm is the next one that we have. And so an aneurysm has a bunch of different grades to it, but basically all it means is it's a ballooning of the blood vessel. And it's usually blood vessels that are under high pressure. And it's caused often by a weakening arterial wall. So if you have a weakening arterial wall, what's going to happen is those pressures are going to hit that weak spot, and it's going to start to bulge out and balloon out. Now, some of our patients had aneurysms, and they were living with them. Because when you take a look at an aneurysm, it's not just a burst, it's a swelling. And depending on the extent of the swelling, sometimes the cardiologists take a look at that. They usually will identify those by ultrasound. So like, for instance, if you've got a carotid aneurysm, they will do a carotid ultrasound and they'll be able to see the physical bulge on your carotid artery. And depending on the severity of that bulge, they will either choose to monitor it, to keep an eye on it, or they will decide to treat it right off to make sure that that doesn't burst. Because what happens is if you continue to swell to the point where it bursts, aneurysms are almost immediate, instantaneous death. Because they are the high pressure vessels, the aorta, whether it's the arch or the thoracic aorta or the abdominal aorta, it doesn't matter, anywhere along there, because we had some patients that had actually an aneurysm of their abdominal aorta, slight swelling there, and they had to be monitored. They had to routinely come in to have that checked. But any burst along that range has high pressure in it, so it's a complete bleed out, like within seconds, literally seconds. This is one of those ones where if it bursts in there, it's like you're literally like walking and talking, and then the next second, boom, you're down, you're dead, you're hitting the floor, right? I mean, it's literally that quick. That's what aneurysms tend to do, and they tend to be quite severe. And so the weakening can either be congenital. We see a lot of those. Just a natural congenital basically means it's just a defect of development. So when you were developing in your mother's womb, it's just that the structure of your arteries didn't quite come together optimally, and so there's a weak spot in your aorta. So we had a lot of those. There was a lot, however, that had atherosclerotic weakening. So basically hypertension constantly beating against that arterial wall will start to wear it down and start to create a weak spot in that arterial wall that will create aneurysm. Also, atherosclerosis, when you get that abnormal plaquing in there, will start to compromise the normal structure of your arterial wall, causing it to become weak and bulge out. All of these basically need to be monitored. And so if it ruptures, it's pretty much gone. right? There's no getting you to the emergency room. You're like dead on arrival. You're pretty much gone. It's very quick. It's probably one of the quickest causes of death that we have. So a couple of more disorders that we have. So dissolving blood clots. So we have a couple of disorders of blood clotting, right? So hemophilia, for instance, is an example of one. Well, let's take a look at blood clotting because we have talked about blood clots. I'm going to sort of get an idea what they're supposed to do normally. So blood clots normally are supposed to keep you from hemorrhaging when you damage your blood vessels, right? So you have platelets in your bloodstream that coagulate and sort of plug up the damaged area of the vessel to keep it from bleeding out. That's what it's supposed to do normally, right? However, if you have an abnormal clotting factor in there, it can cause either abnormal clotting, aggressive clotting, which will essentially start creating these thromboembolisms. That's what clotting is. Or your clotting factor will create an abnormal thinning of your blood. That is to say, your blood won't clot fast enough, right? And so when you take a look at injuring yourself, how many of you guys have cut yourself, right? Usually you don't worry about it, right? Because it's bleeding, but you're thinking, no worries, right? You wait a few minutes, and what's going to happen? It'll coagulate, and it'll stop bleeding. That's the blood clotting process. So the blood clotting process is designed for your blood to kind of coagulate, to stop bleeding so that you don't bleed to death. Somebody who's on a blood thinner or has abnormally thin blood, or like a hemophiliac, who has a genetic disorder in one of these clotting factors, can bleed out internally. There's a lot of damage that happens internally that you don't even know about, that your clotting factors will clean up and fix that you're not even aware of. Or like a bloody nose, right? I mean, we all get bloody nose here. It's usually not an issue, right? We just kind of plug and tilt, right? Plug, tilt, right? Or we can pack our nostrils. And for the most part, right, with very little maintenance, the bleeding will stop and then our coagulation will kick in and then we're good. But somebody who's a hemophiliac, that bloody nose can be a life-threatening moment. You literally can die from a bloody nose if you have hemophilia. So let's take a look at the converse, the over-clotting situation, the thromboembolism issue. So one of the ways we can treat thromboembolism is by administering what's called TPA. This is tissue plasminogen cofactor. Now, plasminogen is an enzyme that breaks up fibrin. Now, fibrin is a protein in your bloodstream. It's in an inactive form, fibrinogen, but this is part of your blood clot. So one of the things that you do is your platelets will sort of close up the hole, and then fibrin will come in there and basically inject itself and reinforce that blood clot to make sure it doesn't break free. So think of fibrin as like rebar in cement. It's like little filamentous protein rods that creates tough structure of that clot to keep you from bleeding out. That's what's in a clot. Plasminogen will break up that fibrin and thereby will break up the clot. That's the reason why we administer it to patients who have blood clotting issues. So what'll happen is TPA will actually take plasminogen and it'll turn it into active plasmin. And that plasmin will then go and basically dissolve fibrin. And that'll break up your clot. So one way to prevent thromboembolism is by taking an aspirin. Matter of fact, a lot of times people with heart trouble will carry like a little bottle of Bayer, just basic aspirin. We're not talking about the fancy schmancy stuff, like Tylenol, Motrin, that kind of stuff. Those aren't aspirin. Those are different medications. Ibuprofen is a different molecule that does different things. This is just basic plain Jane aspirin. And so if you take an aspirin tablet while you have heart trouble, is aspirin can basically thin the blood. And so this will basically reduce clot formation by thinning out the blood. And then that'll keep your blood flowing so that it doesn't basically block the artery. This will get you past those initial stages of heart attack, right? This is basically treated when angina sets in. The idea here, what's causing the angina is an occluded artery. So one way, if you can't dilate the artery, because you don't have a dilator right now, right? One way to keep the blood flowing past that blockage, which is what you're feeling, is you're feeling the cessation of the blood getting through that. It's being blocked by that narrow vessel. And so your heart is starting to feel that deficiency, and that's where it starts to have pain. So if you take the aspirin, since it's a blood thinner, what it'll do is it'll thin out or basically act against the clotting mechanism, thinning out the blood so that the blood can move more swiftly past the blockage and you can restore blood flow, basically eliminating the chest pain. So the thing is, however, that you don't just take your aspirin and then go home, right? And just live your life and go barbecue a bunch of hot dogs and steaks and eat, drink, and be merry. The idea here is to keep you alive long enough so that you can then go and see your doctor and tell them, I had an episode of angina. I had to take my aspirin. It got me past it. But the idea is you don't ignore that one, because what that's telling you is that you've got a blockage in your heart. Today, you got lucky. Tomorrow, you may not be so lucky. So it's kind of a little bit of a warning call to you. So just remember that when you guys get older and you kind of feel that pain in your chest, go grab some Bayer, take it, and then call your cardiologist right away, right? Because they'll probably want to drop a stent in there or something like that. And it's better to live with a stent in your heart and have a very close relationship and a routine relationship with your cardiologist than it is to not live at all. Okay. We got to know our patients really well because they had to come back all the time to be closely monitored, right? So what I do now, I was the education guy. So actually I did everything because it was a smaller office. So I actually had to do lots of things. So I had to bring the patients in. I didn't check them in. It wasn't like an MA. I was like the business side of the office. But I had to do like all the education stuff. I had to check them in, get them settled. I did scheduling, insurance. I did all the hard stuff that nobody wants to do, basically. But I also had to like explain to patients like, okay, so we're doing a stress test, and this is what you want to do. So this is this is how we're doing it. This is what we're looking for, and those sorts of things. So to kind of help them with their instructions, because usually I notice when you explain that to patients, it makes the instructions make more sense to them. Like, this is why you have to do a 24-hour fast, right? When you do this, this is the reason why after we inject a contrast into you, we need to have you eat lipids to clear that out of your system because it's lipid soluble, right? So we kind of had to explain some of that stuff. And I was the harmony guy, right? So cardiologists notoriously are called out of the office because most of the time it's the cardiologists who are on call for the ER. So when somebody comes in with a heart attack, the cardiologists were the ones that got the call, and they basically said, listen, I'm talking to you right now, gotta go. And so they go downstairs, and of course, we have to clean the mess up. So we have to kind of explain to the patients, like, so this is what's happening. Dr. Jantz had to go down to the ER because we've got somebody down there that he needs to take care of. And so here's your options, right? You can either wait, and a lot of his patients did. A good doctor, you can tell a good doctor, because his patients are willing to wait for hours for them. And heart patients typically are very loyal because many of Dr. Jantz's patients, and I think he's retired now, he's a great doctor. I mean, he kept so many people alive. I mean, he's an amazing man. There's not a lot of doctors can say that about, but for him, he kept people alive for a long time. I mean, this guy was great. One of the greatest doctors I've ever seen. And that's a lot. That's a lot for me to say that because I'm not generally impressed by doctors in general. But this man was amazing. And I mean, his patients, they would oftentimes tell me, it's like, listen, he's probably going to be down there for a couple of hours. So you can either reschedule or you can wait. And so many of his patients will be like, we'll wait. Because and then they'll look at me, I'm like, I'm sorry, there's nothing I can do about it. But they'll look at me like, don't worry about it, because you know what? When I was in the ER, Dr. Jantz showed up. So there's a lot that it's kind of an amazing thing to do. You get into cardiology, go get into cardiology if you have a chance to. It's tough because you get to know people, but man, the people who are walking through that door were like, I basically am lucky to be alive. I mean, they're just like, they just realize like, wow, this was almost it. And now I'm here. I'll do whatever you tell me to do. I'll wait for as long as you want me to wait, because that was me not too long ago. So a lot of patients were like that. And that's one of the reasons why I had to leave, is because I couldn't handle getting to know these people, because you get to know them. I mean, they come in all the time. It's not like just a primary care doctor. It's not like I'm just not going to show up. It's like, these are the people keeping you alive. And most patients realize the only thing keeping me on this planet is this doctor. I'll do whatever they tell me to do. Right. And so you get to know them, but then at the same time, because it's end of life, you also get to see them go. And that just got too hard. I just got tired of getting to know people, getting to know their family, getting to know them by name, and then seeing that look, because that look, the look of death, right? The shadow of death. You can see it when they come in, and it's like, as soon as you see that, you're like, oh my gosh. And then usually right after that, we usually get the news, so-and-so passed away. And I just kind of, it was a great experience, but it was just something I'm just like, I can't do that for much longer, because I can still see them. I can still hear them. The one of my favorites, I can still see him coming in his wheelchair. He's a big Cubs fan. Cubs hat, coat, and he was just nicest guy in the world. And I can still see them. I can still hear myself talking to them. I can't not see them. It's like ghosts in my mind. And you can't do that, by the way, when you're in medicine. Yeah, one of the things in medicine, especially when you're talking about end of life sorts of things, is you have to be able to kind of cauterize yourself a little bit, because you're not going to be able to survive it. And I couldn't cauterize myself. I realized I was like, you know what? These people are gone, and it's not like going away. It's like they're all coming with me. It's like, and that became too much. That's the reason why I had to sort of look at I need to get on the other end of a life cycle, the beginning stages of a life cycle, as we're building our life forward, as opposed to the end of life. So that's why the cardiovascular chapters are like, that's my jam. That's my thing. So, but before I break down on you guys and I get negative evaluations of like, the dude, yeah, it's like the dude was crying in front of us. Yeah, you'll be surprised at how many negative evaluations I get for actually just being a human being. And that's why it's like, I don't care. I don't care. So that's part of what actually motivates me on this end too, right? Because I mean, I still have students that I can still see, but in my mind, you guys are alive and vibrant and young. I mean, some of you guys are still in high school. You're just getting started, right? And so, you guys, sorry. Some of you guys, right? Sorry. But no, that's, yeah, right. So, I mean, so we have everything, but we're all kind of in the same place, right? We're all kind of getting it started. And so that's kind of like it's kind of like exciting. It's like we're all building something. And so it's very different, right? So you become very loyal and you become very attached to your patients. And then when you lose them, it's just like, oof. it's like, it's hard. It's hard to get over that. And I was never good at sort of the cauterizing it. I mean, I keep the stiff upper lip, but I can still see them. I can still hear them. I can actually, there's about half dozen people right now in my head that I can think of that I can still see. So on my deathbed, I'll have lots of ghosts in my head. So hopefully they'll all be there to welcome me once it's my turn to head on. So, but anyway, a couple more treatments of clogged arteries, right? So if it gets really bad, you can do the bypass operation. This basically is a situation where you have a hopelessly occluded artery. And then what you do is you basically take a vessel and you basically just bypass it. Literally just kind of go around it. And that basically restores blood flow. So it kind of goes like this. And it kind of goes around it. Okay. Kind of like a traffic diversion when you have construction work blocking the main alternate route, right? We've all been through those, right? The ones where you have to be diverted onto the oncoming traffic. And so you have to take one of their lanes to kind of, that's basically a bypass situation. And so you oftentimes will use a vein from your leg. You can also use veins from other sources as well, but mostly you'll use a vein from your own leg usually. There is gene therapy, so this is a little less common. For instance, you can basically inject what's called a growth factor, an endothelial growth factor for vascular structure. And this will basically allow you or stimulate your body to grow new vessels. And that'll basically disallow you from needing to do the bypass surgery. So basically what you do is the same thing, only you just grow new vessels around that area, right? This is less common. By the way, in all my years in cardiology, we never once had a gene therapy patient, okay? Because there's a lot of experimentation with gene therapy. Sometimes it works, a lot of times it doesn't. It's easier to have a bypass. We did have lots of bypass patients, okay? But this is worst case scenario. The idea, what you really want to do is you want to basically put a stent in there. That's the most common thing to do. So you basically use angioplasty, which is like a gigantic balloon that you insert into your artery. And then you blow it up. And then you insert a stent, which is basically this sort of mesh cylinder that essentially holds your artery open. But the problem is, this is foreign. And anything foreign in your body is going to be subject to rejection. And so oftentimes if you have a stent in there, you're going to have to start taking different types of medications, maintenance medications. And so a lot of these will be coded now. We have coded stents now. We didn't used to before, but now we have coded stents that will basically release drugs that are designed to dissolve those blockages. Because what will happen is that stent will be a nucleation point where your platelets will want to stick to the stent. And if that happens, that's a problem, obviously, because you're going to fill that stent in, it's going to block it, and that's going to be an issue. So a lot of times you'll have medicated stents, or you will have to take medications to keep that open. Oftentimes people with stents will also be taking blood thinners, things like Coumadin or warfarin, which is actually rat poison. Rat poison actually works by making the rat's blood so thin that it essentially bleeds to death internally. And so we take the same thing. So we give our patients rat poison. The idea is we need to thin their blood down so it passes smoothly for the stent and doesn't start to coagulate onto the stent, creating blockages. Now, if you're taking blood thinners, which you would be if you have a stent in your system, you're going to be coming to the doctor's office probably every 2 weeks. The doctor's not going to see you. Then it'll probably be a nurse or an MA, because all they need to do is what's called the ProTime test. All they do is they just stick your finger and they measure how long it takes to coagulate. And then based on how long it takes, they adjust your blood thinner to either thicken your blood up if you're running a little too thin, or thin your blood down if you're running a little too thick. But generally speaking, that is like a routine sort of a thing. And so we'll oftentimes have ProTime clinics where you just basically come in and you just have your finger stuck and measured, and then the nurse will adjust the medication. So that's something that usually our nurses will do. The doctor doesn't need to do that. So it's kind of what a stent looks like. So here you can see you've got your balloon that you're blowing up, and you kind of got this little metal collar that you stick in there, and that's going to stick behind there. It's going to create an expansion area where the blood can pass through easily. And so that's what you would do in these blocked vessels. This, by the way, if you do have a blockage, the cardiologist will schedule you for a visit to the cath lab, where they essentially take a catheter and they thread it up through your femoral artery, goes all the way up to your heart, to the coronary that is blocked, and then they'll poof that open with the angioplasty, and then they'll drop the stent in there. And so that's how they place the stents. And so that's usually like a one-day thing. It's not like a, like a major thing. That's usually a couple of hours, a few hours in the morning. And so it's actually quite effective. The nice thing about this, and the one thing I did love about my time in cardiology, was that we know so much about cardiology now, where we can extend your life by a lot. So it's not just, oh, well, you're just going to live a few more days. It's like you can live years with the kinds of things we're able to do, as long as we catch it in time, right? So like when you start to have that chest pain, you have to get into your cardiologist and take it seriously, because you don't want to be the one where your first heart attack is also your last, right? We have to be able to get to it first. That's the reason why at a certain age, it's advised to just have your cardiologist work you up. Have them do a stress test. See what's happening. Because whether you eat an immaculate diet or not, this is the big kind of fiction. We think that, oh, well, as long as I don't eat any donuts or chips or hot dogs, some of my favorite foods, by the way. So I knew how to communicate to do better. I just can't do better myself. I know my weaknesses, right? But whether you eat an immaculate diet or not, I mean, you could be a vegan and eat nothing that casts a shadow and have a perfect diet, and you're still going to accumulate arterial wear and tear. Your cardiovascular system is still going to break down. You're still going to get plaquing in your arteries. It's just something that occurs with age. It's just part of that sort of cardiovascular wear and tear breakdown that happens as we get older. This is one of the reasons why, as you get older, you want to at some point be like, you know what, I want not the primary care doctor, I want a cardiologist to kind of kick those tires and kind of just see how it's all looking in there. Because you don't want to go in and get that chest pain first before you go into the emergency room, right? You want to catch that ahead of time. And so when you catch that ahead of time, your prognosis is so much better. Because here's what happens. When you have heart failure, your heart stops pumping. It stops pumping properly. But often this is due to lack of oxygen. Any cell in your body, if it's deprived of oxygen, will die. If your heart cells die, then they will no longer be able to contract, and your heart will no longer be able to pump. Now, here's the thing. Even if you survive that heart attack, the cells that died during that heart attack, even if you're able to kind of recover from it and your heart is able to come back and you're able to still live, that damage that you did to those cells persists. And it converts to scar tissue. And the more of these episodes you have, the more scar tissue you tend to build up. And the more that scar tissue starts to occlude and get in the way and create an obstacle to the normal functioning of your heart. So if you don't get that first heart attack, then your heart should be really, really, but you want to eliminate that damage. You want to eliminate that scar tissue. This is the problem with waiting until you start to have your first heart attack before you see your cardiologist for the first time. This is the reason why it's better to catch that ahead of time by doing just a general screening and having the cardiologist run a stress test on you that will allow them to pick up on that blockage level. Because then your heart will not have any damage and you'll be able to have a nice, clean pumping heart. The second you start to accrue damage, your heart is starting that process, that slippery slope down. And then all we're doing after that is extending the length of that slope. Okay. But if you catch it beforehand, you won't be on that slope. Okay. So ultimately, some of the treatments we can do for this is we can wrap the heart if it's starting to enlarge, which is one of the things that happens when you get an abnormally a heart that's pumping abnormally. If it's a rhythm issue, right? With our conductive system or SA node issue, we can set it up with an ICD. An ICD is different from a pacemaker. A pacemaker is a different type of a device. Is basically when your SA node is not functioning properly, it's not firing properly. What the pacemaker does is it kind of takes over that metronomic firing of the SA node and kind of helps that SA node kind of fire rhythmically. It restores that rhythm. An ICD is different. This is basically a defibrillator. This is the paddles. Clear, right? That's what this is. So this one will happen is it won't do anything until it senses an irregular rhythm. So when your rhythm starts to get out of whack, like for instance, ventricular defibrillation, what'll happen is this will fire and it'll be like a little mini paddle, right? The paddle's inside your chest. So rather than waiting for the paramedics to get here and to basically put the paddles in your chest and shock you back into rhythm, you have an automatic shocker in your system because you're prone to getting out of rhythm. And so it'll shock you back into rhythm as soon as you start to fall out of rhythm. If it gets really bad and there's too much damage to the heart, you get a heart transplant, which oftentimes is actually quite useful. A couple of more experimental cutting edge sorts of things is stem cells. We use stem cells to repair the heart. We actually never saw stem cell therapy. We did have some transplant patients. So transplant patients, if you get a transplant, you are in your doctor's lap all the time. I mean, you are there all the time because they have to keep a very close eye on you because you've got not just heart issues, but you've also got rejection issues, and they need to keep track of your medications like routinely. The longest we went without seeing a transplant patient in our office was about 3 months. So they had to see their doctor every 3 months because they have to keep a really tight line on those medications, those anti-rejection medications that they constantly take in order to make sure that heart is working properly. An LVAD is basically a battery-powered pump that's basically a replacement for your left ventricle. This is if you have a lot of left ventricle damage, but the right side of your heart seems to be okay. So you can put an LVAD in there, which will kind of take over the pumping responsibilities of your ventricle because now your left ventricle is it's just damaged beyond repair. And so you can replace it with an LVAD, or you can go basically for a total heart. This is at both sides, right and left, are too damaged to be able to do their job. And so this is kind of what it looks like. So here's kind of your artificial heart. You can see they're not very, cool looking. They're just basically pumps, just mechanical pumps that will just basically do the pumping for you. And so here you can see your mechanical heart in there. So notice you kind of got our stuff connected to all sorts of wires. And so this one as well, you'll have a very close relationship with your doctor. But it's amazing, some amazing things we can do in cardiology. Okay, so that's the end of 5. You're probably thinking, oh, well, we must be done with cardiovascular system. Yeah. Let's see if I can load 6 up here because I don't think I've done it for us. Chapter 6. So basically we're going to be taking a look at blood, because that's like the final piece. So we talked about vessels, we talked about the heart pump, and now the blood is the last piece of the triumvirate of the cardiovascular system. So when we take a look at the heart, roughly with each contraction, you're pumping out about 75 milliliters of blood. And we sort of saw before that on average, you're beating about 70 times per minute. Of course, that varies, right? So if you are stressed out or if you're working out, that's going to be higher. If you're relaxed, it's going to be lower. Basically within probably 60 to 80 beats per minute is your average heart rate. And so when you take a look at a per minute load using these numbers, then at 70 beats per minute, your heart will be basically pumping out roughly about 5.3 liters of blood. If you want to know how big a liter is roughly a quart. So it's roughly a fourth of a gallon. So a quart bottle, which is probably about the size of Dana's drink, maybe around that. That's about the size. So you're basically pumping out over 5 of those per minute. So that's actually more than a gallon per minute on a per minute basis. So your heart is basically a busy, busy organ. And so within each minute, your entire blood supply is going to be circulated throughout your body within a minute. So we're not talking about a slow process. It's a very fast process. Okay, let's take a look and see what the functions of blood are, because this is going to be the key piece, right? So first of all, the blood is responsible for transport. Transport of what? Well, all the things we've been talking about up to this particular point, right? So for instance, your oxygen levels, your nutrients, we talked about that with our hepatic portal system, the waste that we're picking up from the tissues, like carbon dioxide, for instance, and other types of organic wastes. Ammonia, for instance, is a good example of a waste. And hormones, right? This is how you're basically distributing hormones throughout your body. So you're transporting just about everything that needs to be moved to different areas of the body, depending on what the needs of those tissues are. It's also going to be involved in defense, right? So basically your blood is going to be trafficking a lot of blood cells that are involved in your immune system. Basically, you're going to be attacking and invading pathogens. One type of cell they're going to be taking, moving around is what white blood cells. So typically these are cells that will phagocytize these pathogens. So basically they engulf and eat. That's what phagocytizing means. They'll engulf it and eat it up. Other cells will produce antibodies, and so you have to traffic those throughout your bloodstream as well, and so forth. And there's other that will actually just disable pathogens, making them unable to function properly. Also, you're defending yourself against fluid loss. So clotting is the entire fluid loss component, right? So there's a lot that's kind of protecting yourself from it. Regulation is a big function of your blood, because basically, number one, it's going to really regulate body temperature. So basically, blood is the source of your body heat. So you move your internal body heat through your blood. You have hot blood. That's what makes you hot. That keeps your internal body temperature. You're also going to be regulating things like, for instance, different types of proteins that are going to be dissolved in your plasma. Some of them are going to be dissolved to regulate osmotic pressure. We talked a little bit about that in the capillary. Right? That's that sucking effect, that salt sucks pressure that causes water to move inward. So you can regulate that. It's also involved in that salt water balance, which is also osmotic maintenance. That is, say, maintenance of water in your system. Okay. It'll also regulate blood pH. And typically your physiological pH is hovering around 7.4. So that's kind of a consistent pH that you're going to see in your blood. And so all those are different functions of your blood. So it does a lot, right? So it's got a lot of work to do. And so it is true that basically the life of your flesh, of your tissues, is in the blood. All the things necessary for living and for your tissues to be alive and functional is delivered by your blood. So your blood is critical. It is kind of your life elixir, essentially. So what's in it? Let's take a look at it. So if we spin your blood down, we're going to basically kind of spin it down into two pieces. So I'm going to draw a test tube here of your spun blood. So if we spin the blood down, we're going to basically have on the bottom a pellet of cells called formed elements. These are basically the pellet in spun down blood. So these are your formed elements. It's the cells. It's a fancy word for the cells that are in your blood. Then you're going to have a straw-colored fluid on top, which is your plasma. Okay. So that's the liquidy portion. So the plasma is actually the connective tissue that we think of. Remember we talked about blood as a fluid connective tissue? It's the plasma that's the connective tissue because this fluidy matrix is what's supporting the cells that are in it. So it's a supportive structure. So there's a lot of things in the plasma. We'll talk about the plasma here in a second. But in the formed elements, what are we going to find there? First of all, we're going to find the main cell type in there is the red blood cells. So these are what's called erythrocytes. And so these will also contain stem cells associated with them, but mostly red blood cells. We'll also see white blood cells in there, or leukocytes. Leuko means white, cyte means cell. So it actually means white cell. So these are basically all of your immune cells. And they're also your platelets and your thrombocytes. So these are also part of blood clotting. So all these are factors that are in your blood as formed elements. That's kind of what it looks like when they form. So when you're forming these formed elements, they all start in your bone marrow. So you can see this person's femur right here. That's what we're going to start with. Inside that bone marrow, you have stem cells. Now, the job of a stem cell is essentially to divide. So here's what it does. Basically, it'll divide into two cell populations that are identical to each other. One of those will be the stem cell replacement. It reproduces itself. The other one will be some sort of a cell that will then differentiate into whatever you want it to become. So whatever cell you want it to become is basically what we call differentiation. That process of turning into some sort of a cell is differentiation. And so, like for instance, your skin cells are constantly replacing themselves. And so those stem cells will replace those and add a new fresh batch of cells, which will then basically become the new skin cells. And then since they reproduce themselves, you always have a stem cell to add to that population. Okay. And so in this case, you have stem cells that will reproduce. And the cells that they differentiate will form the different lineages of the cells that you see in your formed elements. For instance, you'll have the first cells that come off of your stem cell or will turn into what's called erythroblasts. A blast cell typically refers to a developmental cell. This is not a terminally differentiated cell. This is not a cell that's all grown up and ready to do a job. This is a developmental cell, so it's still in production. So erythroblasts will then differentiate and mature into red blood cells, erythrocytes. There are other types of cells, however, that these stem cells will produce. So they'll reproduce and they'll create what's called the cell lineage for the white blood cells. For instance, you'll create what's called lymphoblasts, which will develop into lymphocytes, monoblasts, which will develop into monocytes, and myoblasts, which will develop into both neutrophils and eosinophils and basophils. So this has basically three different lineages. These are all your white blood cells, this group here. And these are your red blood cells. One of those cells, called the megakaryoblast, will actually develop into platelets. So you can see all the components of your immune system, right? Some of these cells are phagocytic. They'll engulf pathogens and destroy them and kill them. And some of them are not. And some of them, like platelets, are designed to clot the blood and to be blood clotters. So these are all parts of that formed element. But before we get into the deep woods of these individual cells, let's take a look at the plasma. The plasma is going to be the straw-colored fluid. It's roughly it's not quite over, it's a little over half of your blood. Of course, this depends. So it could be a little more closer to 2/3, a little closer to half. So the plasma is going to be mostly by far water. So most of your blood is actually water. Less than 10% is going to be protein. So things like albumin, globulins, which are like immunoglobulins, antibodies, for instance, are in this area. Fibrinogen, remember we talked about that with blood clotting. So these are all parts of the proteins that are circulating in your blood plasma. Other types of dissolved solutes, for instance, different types of waste are in there, nutrients, hormones are in there, and vitamins are in there. But it's a very small percentage of your plasma. Very potent, though, in function. And then the rest of it, of course, is going to be your cells and your platelets. Okay. So when you take a look at your plasma, most of it is going to be water. About 10% of it is going to be different types of salts and organic molecules, including different types of nutrients, wastes, and hormones that is in there. Now, the important thing about the salts is the salts will basically create osmotic pressure, which allows you to be able to maintain that osmotic balance. Plasma proteins, which are a big piece, are typically made by the liver. And generally speaking, these will shuttle, most will act as shuttles for lipids. And these will also create osmotic pressure in the blood, in the capillaries. Remember we talked about that osmotic pressure creating that sucking effect? Those plasma proteins don't get out of the capillary. That's what these guys are. These are those osmotic, these are those liver plasma cells, those plasma proteins that don't get out. And they create that osmotic tension inside the capillary. And so that's basically the basic components of the plasma. But what I want to do next time is focus in on the plasma proteins and then kind of fill out the structure of blood. And then we'll start talking about how the blood functions and things of that nature. Yeah, this is a good place to stop.